server. Right. So the webinar has started. Evening, everybody. I can see a few people have joined the webinar already. All right. So we'll wait for a few more people to join and kick off in a moment. Okay. Good. So hello everyone and welcome. It's now 7 o'clock in the UK. So welcome to our webinar this evening on the genetics of PKD with Dr. Richard Sandford. So whilst people are joining the webinar, I will go through a couple of introductory slides so that everybody gets a chance to join and hear what Dr. Sandford will be saying tonight. Just a brief introduction. Dr. Sandford is an honorary consultant in clinical genetics in the east of England. He works in a multidisciplinary renal genetics clinic at Addenbrooke's Hospital and sees many patients there who have polycystic kidney disease. He's got a particular interest in understanding how ADPKD progresses over time and the factors influencing this. And I think it's not incorrect to say he's one of the world's experts in PKD. Dick, could you move on to the next slide? Thank you.
Will do.
So this slide just explains how to ask questions in the webinar. Some of you may have been on previous webinars, so you'll be familiar with this. But you should look for a control panel and a Q&A box. Hopefully it will look like this little diagram at the top. You can ask your questions through this Q&A box. These are chat questions, so text questions only. And you will also have the opportunity to ask questions anonymously so that your names aren't visible. We'll try to answer all the questions that you're asking this evening, but it may not be possible in the time. We'll go rather quickly. If you've got follow-up questions, you can always email me on info@pkdcharity.org.uk. And I am Tess Harris. The webinar will be recorded and uploaded onto the PKD website for later viewing. Medical disclaimer, the webinar is for people in the UK. We do make every effort to ensure that the information that's provided is correct and up to date, but it's not a substitute for professional medical advice or a medical examination. You should always consult your GP, pharmacist, or other medical professional if you've got any concerns about your care or your child's care, or before taking any treatment. We don't accept liability for any errors or omissions, and we don't promote or recommend any treatment or brand. Our role is to support patients and families, raise awareness and fund research. And so now I'll hand over to Dr. Sandford to talk about the genetics of polycystic kidney disease.
Good evening, everybody. Thank you very much for asking me to give this webinar. What I hope to do in a relatively short period of time is just to provide you with some basic information about genetics and genetic testing in mainly autosomal dominant polycystic kidney disease. So I hope really that anybody who wishes to find out more about this aspect of ADPKD will find this presentation useful. As Tess said, I'm currently work as a consultant in clinical genetics at Addenbrooke's Hospital in Cambridge. And I work alongside Professor Fiona Corrett, one of my nephrology colleagues, and we run a multidisciplinary renal genetics clinic. This type of model of delivering care for people with ADPKD is becoming, I understand, much more popular, certainly in the UK, with quite a number of centres now having this sort of clinic. However, I think many of you probably will not attend such a clinic, and at the moment that's largely because genetic centres tend to be concentrated in larger, often university cities. So sometimes gaining access to such a clinic may not be always feasible. So what I hope to do in the next 15 or 20 minutes or so is just to briefly cover the genetics of polycystic kidney disease. Any one aspect of this talk, unfortunately, I could spend over an hour talking about, but as I said, I'll try and distill the key and most important points. Also, just to sort of review what we really mean by genetic testing, when you might be offered a genetic test, and what really do the results mean both for you and other family members. I'm often asked in clinic whether I have to have genetic testing, and of course it's based on the reasons that it might be being considered, but it's certainly not an essential part of anybody's care, although it can certainly add important new information in the context of both diagnosis, treatment, and ongoing care. Many people also ask whether they should tell their family the result of a genetic test, and similarly, a more common question now is whether or not genetic testing is suitable for children. So I'll try and go through each of these particular points, just using specific examples. So I won't be able to cover everything, but I hope I'll cover just enough to be able to answer most people's questions. One of the things that has always struck me about running a clinic for individuals and families with this condition is how many people come into clinic and have been told that they've got adult polycystic kidney disease. Well, the A is for autosomal and not adult. But what does autosomal mean? The picture in this diagram is a picture of what the chromosomes in each of our body's cells look like if we were able to lay them out looking like this. So we have 46 chromosomes and they occur in 23 pairs, and one of each pair is inherited from each parent. Chromosomes 1 to 22 are called autosomes, whilst the 23rd pair, either XX and a female or XY and a male, are called the sex chromosomes, and they determine whether we're male or female. So you can see that the autosomes, or autosomal in ADPKD, refers to that first set of chromosomes. And the reason for that is that at least 20 years ago or more, it was identified that the two genes, PKD1 and PKD2, that are responsible for most cases of this condition are present on chromosome 16 and chromosome 4. So these are autosomes. So these are not chromosomes that determine gender. They contain the rest of our genetic makeup. So that's the autosomal part of this particular condition. And as you can see, about 85%, or between 8 and 9 out of 10 people with this condition have a genetic alteration that's located on chromosome 16 in the PKD1 gene. So what about dominant? Well, dominant refers to the pattern of inheritance. So many people with ADPKD will be very well aware of the genetic nature of this condition because the majority will have an affected relative, either an affected parent or an affected sibling, a brother or sister. And this is largely what dominant means, that this is a condition that can be seen from generation to generation, and it also affects males or females because the genes are on the autosomes and not the sex chromosomes. What it also means is that only one altered copy of a gene is required to cause the condition. And you can see this in this cartoon that's taken from the PKD charity website. We have 2 copies of each particular gene. And what you can see is that for an individual with polycystic kidney disease, they contain an altered copy and a normal copy. And as only half of our genetic makeup is passed from parent to child, you can see there is a 1 in 2 or a 50-50 chance of passing the altered copy onto a child. The other possibility is that the other child will inherit both a normal copy from the affected parent and a normal copy from the unaffected parent. So for an affected individual, there will be a 1 in 2 or a 50% chance of having a child with the same condition. And this also applies to an individual with ADPKD with no family history. When they go on to have children of their own, it's the same chance. And the risk is the same for each child that a family may have. The fact that a couple may have had an affected child or a healthy child first doesn't alter the risk for each subsequent child. So that's autosomal and dominant. And so therefore that gives us the name of the condition, autosomal dominant polycystic kidney disease. I'm not going to be speaking about autosomal recessive polycystic kidney disease, as that is quite a different condition, and I hope that will be covered in a separate webinar. But recessive there, very, very briefly, means that both parents are carriers of an altered copy of a particular gene and have an affected child when the child inherits both affected copies. What do we mean by genetic testing? Well, you can see in this particular picture, there is a cartoon of a chromosome. The chromosome is made up of our genetic material, which is DNA, and you can see that as the DNA unravels, it's compared of so-called base pairs, and there are 4 separate bases, A, C, T, and G. What we really mean by genetic testing is that we're trying to sequence or read the genetic code in a particular part of our genome, or for example, for PKD1, a region on chromosome 16 where the PKD gene lies. Genes are made up of long stretches of DNA broken up into different parts, which is illustrated here. Exons in green and introns in purple. The exons, in a process of transcription, are in a sense glued or spliced together to form an RNA molecule, and this then forms the template for the production of a protein. So DNA in the form of a gene, which we have here, is the basic template for the production of proteins. What we do in genetic testing is by reading the code, reading the sequence of a gene, we hope that that will then allow us to firstly identify a change that is associated with disease, and then to predict the effect that that change will have on the protein structure. Here is one of those exons, and exons, as we've just said, contain the important or coding part of a gene that encodes a protein. So for the DNA sequence part here, I've just put a random sequence here. And for example, this would be in PKD1 or PKD2 in an individual with ADPKD. And that particular sequence is predicted to produce a protein sequence, which I've represented by these colored circles here. And in the case of polycystic kidney disease, this protein is either called polycystin 1, if it's made by the PKD1 gene, or polycystin 2 if made by the PKD2 gene. There are other names for these proteins which you may have read about. The 2 commonest types of genetic alteration that we identify in individuals with ADPKD are written here below. The first one is what is called a nonsense mutation. That is where a particular alteration has occurred in one exon. And in this particular example, this C here has changed to a G. And this particular part of the exon, this 3 base pair sequence, TAG, actually prevents the protein chain being built up. So this stops a normal protein being produced, and we would predict that this protein has no further function. In this particular situation, for example, this G here has been changed to a C. What that does is that it alters that particular amino acid or part of the protein to a different one. and that may well stop the protein function, or it may just alter the protein function, perhaps allowing the protein to be less efficient at what it does. But what we are aware of in both of these situations, having either a missing protein or an altered protein is capable of giving rise to the clinical condition, the disease called autosomal dominant polycystic kidney disease. There are other genetic alterations that can also give rise to ADPKD. I won't go through these in particular detail. There is certainly information available about this, and I will try and put some further information up about this after this particular talk. But in addition to the two changes I've already mentioned, it is possible that one of these bases here is missing, for example. That would be called a deletion. Sometimes a stretch of DNA is duplicated or present in an extra copy. And we also know that it is possible for an extra base to be included, and that's called an insertion. All of these changes have the potential to lead to either loss of a normal protein or altered function of the normal protein, so giving rise to autosomal dominant polycystic kidney disease. As you've heard, we've known about the PKD1 and PKD2 genes for quite some time, and certainly within the NHS, genetic testing has been available since approximately 2008. So we've got about 10 years worth of experience in this particular country. And genetic testing in the UK is largely regulated by an organisation called the UK Genetic Testing Network. And this particular organisation provides a lot of information about specific genetic tests. These are pictures here describing the entire PKD1 and PKD2 genes. And in this particular situation, you can see that the PKD1 gene is made up of 46 exons, the PKD2 gene 15 exons. So these are relatively large and complicated genes. But using a DNA sample, PKD1 and PKD2 can be completely sequenced or analysed in an individual. And using that sequence of all the base pairs in a gene, that can be compared to the reference sequence or a sequence from a normal individual or a large number of normal individuals to determine whether there are any significant alterations that we would predict would cause disease. And those alterations we also tend to refer as mutations. Mutations are not always easy to find, unfortunately, and an awful lot of what we would call informatics or interpretation of the DNA sequence is required to be confident that any alteration we find is the cause of disease. It, I think, is generally accepted from the very large number of centres who do genetic testing for this condition that for somebody in whom we are clinically fairly certain has the condition, our ability to find a mutation is about 90%. So that still leaves us with 5, 10, maybe 15% of people who've got this condition based on scans, for example, but we still can't find the underlying genetic alteration. But in the next year or so, certainly within the NHS, our ability to identify those missing changes, I hope, will improve as we move to a much more complicated form of genetic testing, which is called whole genome sequencing. But I think one of the other points to make at the moment is that there is considerable variation in the use of genetic testing. Some clinics, some centres tend to use genetic testing far more frequently than other centres, and I know that probably the majority of people with this condition at the moment will not know what the cause of their condition is within their family. But this is something that is likely to improve over time as access to genetic testing improves. Generally speaking, the reasons to consider genetic testing fall into a number of distinct groups. However, for the majority of individuals, either with ADPKD or a family history of ADPKD, imaging using ultrasound, CT or MRI remains the commonest diagnostic and screening investigation, and these are still extremely good tests that have been around for a considerable period of time. However, in addition to this type of imaging investigation, genetic testing can also be used in a variety of other situations. To confirm a diagnosis is perhaps the commonest reason for considering genetic testing, and that can be done in a number of situations. Sometimes we see infants and children who've got kidney cysts, and it's not known whether that represents a diagnosis of ADPKD or perhaps another type of polycystic kidney disease. And so genetic testing then is entirely appropriate. Sometimes in children, teenagers, or adults of any age, the clinical suspicion is of ADPKD, but the scan results are equivocal or unusual and don't currently fit with our clinical guidelines in terms of diagnostic appearances. And so in this situation, genetic testing is also reasonable to consider. Some individuals who have recently been diagnosed with a condition that most likely represents ADPKD but have no family history, genetic testing again can be used to confirm the diagnosis. More frequently, if the genetic alteration in a family is known, then this genetic alteration can be used to offer what we call predictive testing to an individual in the family who may not know what their clinical status is, whether they have the condition or not. And this is especially true in younger individuals, and I'll come on to that in the next few slides. Again, although it is not essential or necessarily offered to anybody undergoing living-related kidney donor evaluation, it's becoming increasingly used in that particular situation, predominantly with the aim of excluding the condition in a potential donor. And again, this requires the underlying genetic alteration in an affected family member to be known. Some individuals and couples also would like information about the genetic cause of their disease so that they may consider whether it is appropriate to use that information to perhaps help them and inform them in planning their families, and certainly to consider whether prenatal or pre-implantation genetic diagnosis might be something that they would like to consider. However, testing in that sort of situation is likely only to be offered through an expert genetics or regional genetics clinic. And the last point I wish to make, which again I will come back to in the next few slides, is that identifying the underlying genetic cause of ADPKD in an individual or family can also provide information about the likely rate of disease progression or disease severity over time. And so genetics is now forming part of what is sometimes called risk scores. The vast majority of people will have their disease confirmed using an ultrasound scan. And for many years, we've had very good criteria for the diagnosis of polycystic kidney disease using an ultrasound scan. As the majority of people don't know whether they have a genetic alteration in PKD1 or PKD2, you can see that as we get older, more cysts are required to confirm the diagnosis. And as more cysts are identified, that means an ultrasound is a very good test. But it doesn't always confirm the diagnosis in everybody having the test. And the younger you are, sometimes the harder it is to confirm the diagnosis, perhaps if less than 3 cysts are seen. And so this is one reason why genetic testing can be offered for somebody in this age group here, for example, who wants the certainty to know whether they have the condition or not, but the ultrasound scan is equivocal. Genetic testing can be offered again if the underlying genetic alteration in the family is known. However, we now know that with MRI scanning, for example, or CT scanning, some of that uncertainty provided by ultrasound can be replaced. So we now know that by using MRI or CT from the age of 16 or so onwards, the presence of 10 or more cysts is highly predictive of either having the disease or, if less than 10 cysts are present, for excluding the disease. So additional tests such as MRI can also be used alongside or instead of genetic testing when there is uncertainty. This is just a schematic of sometimes how we draw a family tree in clinic. And you can see that this just represents 1, 2, 3, and 4 generations of a family. Men are squares, women are circles, and for somebody who has polycystic kidney disease, they're coloured in. So in this particular family, you can see that these 2 individuals have inherited polycystic kidney disease from their father here. And this individual also has a son who's inherited the condition as well. And there are a number of reasons within a family that people may consider genetic testing, as I've already discussed. For example, if this individual wished to be a potential living related donor to another sibling, should they be developing kidney failure requiring transplantation, then at the age of 52, it would be entirely appropriate to offer ultrasound or MRI scanning to determine whether they're affected or not. And again, in some circumstances, depending on the appearances of those scans, genetic testing could also be offered. But in this circumstance, it would need to be offered initially to somebody with ADPKD. And if an alteration was identified, this individual could then be offered testing in the hope that he did not have that genetic alteration. For this particular individual who may be considering screening for themselves, genetic testing is also an option, but obviously needs to be approached with a little bit more caution, because in this situation, the mother here does not know and has not wished to find out whether she has this condition or not. And at the age of 18, an initial ultrasound scan unfortunately was not diagnostic. But as you can see, if this particular individual wished to consider genetic testing, again, it would require the knowledge of a genetic alteration in the family from another affected family member who had had genetic testing. But by having genetic testing, it is also possible that she may reveal, if the test was positive, whether her mother was affected or not. So part of the process of considering genetic testing, it is very important indeed to be aware that genetic counselling, the provision of accurate information, is an important part of this process. And if you look at this recent review in The Lancet by Professor Albert Ong from Sheffield and others, you can see that genetic testing is now very much sitting within the management guideline for ADPKD. It may be required here at the initial first visit, especially if there is diagnostic uncertainty, but typically routine care and management is provided. Often at the second visit, genetic counselling and testing can be considered here, especially with respect to screening at-risk family members, whether or not knowledge of the underlying genetic alteration, for example, will provide additional information about disease severity and risk of disease progression. And potentially also, as I'll come on to show, genetic testing may also guide whether or not treatment is appropriate. So for somebody who has a genetic test, what do the results mean? Well, you may well be shown a copy of your report, and that report often does seem quite complicated, but they're fairly standard reports. It'll tell you which gene has been tested or on which gene an alteration has been identified. It will tell you whereabouts in the gene an alteration has been found and what the alteration is. This means a T has been deleted, and it'll then tell you what effect that has on the protein here. And in this particular situation, it tells you that this position, an amino acid called arginine has been changed to a glycine. But by doing that, what it means is that further on in the protein, it then gives rise to what we call a stop codon, which means that the protein cannot be produced after this position. And so this is very likely going to be a loss of function or a severe alteration. And so this variant results in an abnormal protein and is therefore highly likely to be what we call pathogenic or causing the disease. It, however, has not been reported previously, and we often check all the results of our genetic testing in a wide range of databases to help in this interpretation. So this result would be confirming a diagnosis of polycystic kidney disease, and the result could also be used to offer testing to other family members. However, sometimes results are not so clear-cut, and the evidence may not be so strongly supportive of whether the genetic alteration or mutation is causative. It may be lightly pathogenic, in which case it could be offered to other affected family members to see whether they all carry the same genetic alteration, in which case that might increase the probability that it is causative. Sometimes a genetic alteration is identified, but we really just cannot interpret whether it's going to be significant and cause the disease, and these are often referred to as VUSs, or variants of unknown significance. In addition, about 5 to 10% of tests, as I've already mentioned, there's no mutation detected. These tests are often interpreted as normal, I don't think I would call them normal. It's just that the current test has not been able to identify the genetic alteration. And for somebody clearly who has polycystic kidney disease, this is not going to alter the diagnosis, but clearly additional or better testing in the future may well be helpful. But if no mutation has been detected, then it is clearly not possible to offer other family members testing. How can genetic alterations also be used to perhaps inform us a little bit more about polycystic kidney disease? Well, in recent years, a risk score called the Pro-PKD score has been published by a French group, and that uses both clinical information and genetic information. And it's a point scoring system. So you get points depending on your gender, whether you have high blood pressure before the age of 35, and whether you've had any significant symptoms such as hematuria, and the type of mutation and the gene it is in. And in this very important study, what they've shown is that the higher your score, the earlier your risk of developing kidney failure requiring dialysis or transplantation is. And then by grouping those scores into low risk, intermediate, or high risk, they can make a very clear definition between the likely risk of developing kidney failure, perhaps at a relatively early age, from the high-risk group to a later age in the low-risk group. And putting that in figures, what you can see is that in the high-risk group using this score, the risk of renal failure by age 60 is about 90%, but if you're in the low-risk group, the risk of renal failure by the age of about 20 is, by 60 is only about 20%. Although you should be aware of the fact that clearly what you can see is there is still quite a wide range using these risk scores, and they're not routinely in use in clinics at the moment, although combined with other information, they do appear to be providing additional beneficial information. And similar studies, here's a study done by a group in Toronto in Canada, where they've done exactly the same type of study. They've shown here that the type of mutation and in which particular gene can predict the potential risk of developing kidney failure. And it identifies higher risk groups versus lower risk groups. And what's interesting in this particular study, like the French study, you can see that individuals with a genetic alteration in the PKD2 gene have significantly milder disease than individuals who have genetic alterations in the PKD1 gene. And we've been aware of that for a number of years. And that's one of the reasons sometimes why genetic testing is carried out. But also, reassuringly, that for those individuals who've got a diagnosis of polycystic kidney disease, even if the test is negative and it doesn't identify a genetic alteration, that shows that those particular individuals also tend to have milder disease here. And again, in this Toronto study, you can see that the discrimination between the higher and the lower risk groups is some 30 years in terms of predicting the age of developing kidney failure. So I think these genetic risk scores are certainly going to become much more important in clinics in the future. And as those of you who may be on tolvaptan may be aware, so GINARC, these types of risk scores are also potentially of value for if there's a high risk score in determining whether somebody is likely to benefit from the use of tolvaptan. But the majority of people who've started tolvaptan would have started on the basis of their underlying kidney function or potentially also their kidney size. So genetic testing is another option. It doesn't replace any of these other standard clinical tests. So I've just got my last few slides now. I'm sorry I've gone on a little bit longer than I thought. People don't always want to have testing, and people always, I think, would benefit and prefer to have a discussion about the pros and cons of testing before testing is carried out. This particular process of getting further information is called genetic counselling and is a very important part of the genetic testing process. And I think it's fairly clear what the potential benefits of having testing are in terms of either confirming a diagnosis, identifying the gene, providing information for other family members, in donor evaluation, for example, also defining potential treatment options. And for some families, it's important for family planning. But I think we must also be aware that this type of genetic testing can cause worry and anxiety and uncertainty about the type of result that one might expect, especially starting to get a better understanding of potential future risks of developing kidney failure. sometimes there's an uncertain result, so we can't improve on that with our current test. And similarly, for people who've got no symptoms whatsoever, pre-symptomatic testing to find out whether they've inherited the gene and will then go on to develop polycystic kidney disease can also cause significant worry. But the process of genetic counselling should minimise these as much as possible. People often talk about insurance and careers, and I'm sure this will come up in the questions afterwards, but this is as much as it is important to know about whether you've got the condition or not as to whether you've had a genetic test or not, because the majority of people will have a positive family history, which will invariably need to be declared to the insurance companies. And again, we'll come back to that. For the majority of people, they will tell their family the result of a genetic test, but this is a very personal decision. Your doctor will not do this without your permission. And of course, we've already been through the fact that it may provide valuable information for other family members, and it can be done anonymously. We often provide family letters that people can send round, which don't contain specific patient information. And of course, testing children, this always remains a difficult and slightly controversial area. But for those of you who heard the Managing ADPKD in Children webinar, I think it's becoming much clearer about the reasons that we may consider doing that. It's most commonly requested for diagnostic testing, but at all stages, it's important, if the child is of a sufficient age, to respect their autonomy and ability to consent. It always requires a process of genetic counselling for the child and parents. And it certainly can be considered if it will help with both screening, diagnosis, and treatment or care. Again, for children, the familial mutation typically needs to be known unless it's a diagnostic test. And we would almost certainly never do this type of testing just to find out whether somebody carries the gene. And in the new clinical practice guidelines for young people, it's also considered as part of the screening for blood pressure and ultrasound, but those can be used as first-line investigations more routinely. So genetic testing in ADPKD is available through the NHS, through renal and genetic specialists. It complements but does not replace routine clinical care, including image, but I think very much has aspects that it can add to an individual's care. It's typically currently used to confirm a diagnosis for polycystic kidney disease, for predictive testing to allow people to find out whether they've got the condition, or also increasingly in donor evaluation. It has an increasing but yet to be fully evaluated role in assessing disease severity, and some families may request testing as part of their decision to start a family. So there are a variety of sources of additional information, but I think what we should do now is to move on to answer some of your questions. Thank you very much.
Thank you very much indeed, Richard. That was truly informative. Even I learned a lot about
perhaps a little bit long-winded, and I'm sorry.
Thank you. We do have a couple of questions that come in, and there's a Q&A box at the which I'll just quickly run through those.
Yep. Shall I take the first one?
Can you see that that one now?
Yep. I'll take the first one. Yes.
Yes.
So the first question is, there is no history of polycystic kidney disease in the family background, yet I have twin identical boys who have ADPKD, and how can that occur? Well, we know that about 10% of individuals with ADPKD, if we go back and look at their parents, the parents are unaffected. What this means is that genetic alteration is unique to that individual and has occurred in them for the very first time. So if you have identical twin boys, that genetic alteration in either one of the PKD1 or PKD2 genes has occurred at the very earliest point of the pregnancy. So as they're identical, they share the same genetic makeup, so they both have the condition. But as I say, we see this, what's called a de novo genetic alteration, in about 10% of individuals with polycystic kidney disease. Right, Tess, shall I take the next question?
Yes, and you can tick answered.
Right, so I'm going to go to the next question, which said, would we be automatically recalled for further testing when neither PKD1 or two mutations have been identified in the first test? Well, this is a very important question, and it's one I think the genetics and renal community are currently thinking about, whether we should automatically recall individuals. At the moment, I would say that it is not standard practice, and our advice in my own clinic would be, if this is the situation, for somebody to perhaps raise the question about additional testing in a year or two's time. For those who've had a genetic test and no alteration or mutation was identified, the NHS is going to be offering genetic testing for this condition using whole genome sequencing starting next year. We hope that this is going to be a significant advance in genetic testing for this condition and hopefully identify those so-called missing mutations. But I think it's probably best to assume that you won't be routinely recalled, and this is something that you should ask your kidney or genetic specialist again at some point in the future. Right, I'm going to keep going with the questions. Thank you very much for the questions. They're all excellent. The next question is, we have one child conceived naturally and are considering a second using pre-implantation genetic diagnosis. What will the hospital's position be on testing our first child? Yeah, that is a very, very complicated question, and I don't know how well that has been rehearsed in the context of ADPKD. It is something that I have encountered with respect to other genetic conditions, and the idea of testing a child whose disease status is unknown, I think, is controversial. I think we all feel that testing a child to determine whether they've got the condition or not when they're healthy is a complicated process, and something that I think should be discussed with the PGD Centre. My understanding at the moment is, and I certainly is something that I will clarify for you, is that this is something that would not routinely be, that you would routinely be asked to do. But I said, I think it's worth asking your own PGD Centre about exactly what their guideline on that would be. So the next question is about obviously whether you need to advise insurers that you have had genetic tests done. Well, in the UK, as you are probably aware, there is currently a moratorium, and as much that insurers are, certainly with respect to providing life cover, for example, under a value of about £500,000, are not allowed to specifically ask about the results of a genetic test. However, they certainly are allowed to ask about your health, any conditions that have been diagnosed, and your family history. If, for example, you're having a genetic test to find out whether you've got the condition or not, and the genetic test is negative, then that is sometimes information that you may wish to disclose to an insurer, as that will clearly not have the condition. I'm going to answer the next question. This question asks, is there any genetic testing that can predict the severity of the polycystic liver disease associated with polycystic kidney disease? I think my current understanding of this is that most of what we've spoken about so far provides information mostly about the polycystic kidney disease and not polycystic liver disease. The severity of polycystic liver disease, I think, is probably influenced by many factors that we don't really fully understand, but the genetic influence of that is much less than it is on the polycystic kidney disease. So it would be difficult to make any further assumption about the liver disease based on the genetic tests that I've discussed today. So it is possible, though, that with more broader genetic testing, as we know other genes that can cause polycystic liver disease, it may be that other genetic alterations that are not related to the main diagnosis may have some influence on polycystic liver disease, the development of polycystic liver disease. But I think that's still very much in the research arena at the present time. The next question, I think, is a very, very pertinent one, and one that I often have to deal with quite frequently in my own practice. Can a renal specialist refuse the request for a genetic test in order to assess disease progression and eligibility for tolvaptan. I suspect really the answer to this is that the assessment for eligibility for tolvaptan can be based on quite a number of different criteria, as I've shown, of which genetic testing is one of those. And whether a particular kidney specialist decides to use information from one of those other assessments is, I think, largely down to a conversation between the two of you. Their opinion may be that the information from other tests or scans is more than sufficient to provide the information required to provide tolvaptan. But certainly if there's uncertainty, it is possible for a genetic test to be carried out, and certainly in the next year, genetic testing via kidney specialists will be possible within the NHS. They'll be able to request tests by themselves, or as I've said, a referral to a genetic specialist is another way of perhaps looking at this question in a little bit more detail. And the next one, Tess, am I okay still?
Yes, we've got, yes, we're fine for time.
Good. Right, I'm just going down the list if that's okay. With
yes, you can. There's a couple that might be duplicated, but
okay, yeah, I'll leave you to point those out. And the next question: do you believe it is unethical if people who are known to have ADPKD choose to have children and therefore knowingly risk pass it on? How effective is pre-implantation testing for ADPKD? I think the answer to this is that an individual's decision to have children is a very, very personal decision. And in addition to that, I think we're fully aware that there are a very large number of conditions and illnesses that affect us all. And knowledge of all of those, I don't think would ever make it unethical to decide to have a family at all. For this particular condition, I think it's generally viewed that it is for the majority of people a later onset condition, and there are therapies in terms of renal replacement therapies, including transplantation, that are available. So I think some people choose personally not to have children for their own reasons and beliefs, but for those who do choose to have a family, I don't think it's what I would certainly call unethical. From our own clinic, we have made a number of referrals to our local PGD centre, and some couples have already managed to achieve a healthy pregnancy with that, but the numbers are still very small. But we know that PGD is very widely used for a very broad range of genetic tests, and so I'm sure in the fullness of time, as many more families become aware of it, they will consider whether this is something that they would wish to discuss. And again, if you wish to find out more about it, a referral to your local genetics centre can be made, and they will be able to provide you with information about PGD, and then to refer you on to your local PGD centre. And talking about children, so would it be best to then advise children to wait for tests where the parent test identifies no mutation and no history in the family? I think with respect to children, what we're really thinking about is if there is a family history that says that they're at 50% risk of developing the condition, or if for some reason they've been identified as having kidney cysts, and their own paediatrician is wanting to determine whether this is the condition that they've got. In that sort of situation, it may be possible to offer the child testing, or to find out in other family members whether there's already a known diagnosis of ADPKD. Certainly, it is not unusual when the diagnosis has been made in a child to then go on and offer parents screening in which they were unaware that they had the condition for an ultrasound scan to confirm the diagnosis. So I think it's always best to take all the information on board and consider the appropriateness of family testing in addition to just testing the child. So, is there going to be a PKD3 and a PKD4? Well, there probably is already a PKD3 and a PKD4. So more recently, 2 additional genes have been identified that cause a condition that's very similar to polycystic kidney disease, but generally it seems to be much, much milder than ADPKD, with a much lower, due to mutations in PKD1 and 2, with a much, much lower, if negligible, risk of progression to kidney failure. But it tends to be perhaps associated more with the development of liver cysts. So newer genes are going to be identified, but I think the likelihood is that they're going to account for a very, very tiny number of individuals. But testing for those will become routine within the NHS in the next year or two. I'm going to have a go at this next question. If I'm permitted to read out, is that okay, Tess?
Yes, I think it's fine to read that one out. Yeah. Mm-hmm.
So my father had ADPKD, and my oldest sister was diagnosed 18 years ago in her early 20s and has now developed kidney failure. My older brother was apparently diagnosed as a child, but he's refused to be tested further since. As the youngest, I approached my local NHS genetic testing department for testing and had ultrasounds over 10 years, all showing clear kidneys. However, I was told I couldn't have genetic testing as there wasn't enough familial DNA to compare against. I've since had a son and would still be keen to know if I'm a gene carrier. How would I be best to proceed? Well, in a sense, you're absolutely right. When we're offering this type of predictive genetic testing, that it is important to be able to have DNA from somebody in the family who is known to have the condition that you can then carry out the genetic testing on. For yourself, if it's not possible to carry out the genetic test, as I've mentioned, if there still remains an element of uncertainty based on ultrasounds, then an MRI scan might be the best way forward. And clearly, if you have a completely normal MRI scan, then there will be no risk to your son. So I think that's probably the best way of proceeding with that. I hope that answers your question, but do come back to us if I've missed any particular point there. And the last one, how does the process of genetic testing in the UK compare with the rest of the EU? The genetic test for one of my twins was conducted in Germany and passed on to the renal unit looking after the other twin in the UK. Are our EU friends ahead of us here? That's a very, very good point. I would hope that we all operate to exactly the same standards in exactly the same way. So our practice here would be that if somebody has had a positive genetic test, again, we wouldn't normally inform other family members automatically. We would give the person who's had the positive test a letter with the result of the test, which they can then pass on to other family members. And that's something we certainly encourage people to do so that other family members can benefit from the test result. Certainly in the UK, I don't think it would be current practice to routinely send out genetic information to other people, in a sense, unannounced, if you like. But I think family sharing of this type of information is very, very widespread. I'm going to go to the next question. It says here, I'm the only living relative with ADPKD and have had genetic testing. Will this be a reliable result? Well, I'm assuming clearly if you have ADPKD and you've had a genetic test, then if a genetic alteration has been identified, then yes, it's depending on what the result was, there wouldn't be any reason to doubt the test. If there are no other family members available. The only situation that this might be problematic is if the genetic test in you was equivocal and didn't give a clear-cut answer, in which case there wouldn't be other family members to go and potentially offering testing to, which can sometimes be a valuable way of increasing the certainty in the genetic test result. And the next question, is it possible to ask my renal consultant for a test to identify if I have PKD1 or PKD2? Is there any benefit of knowing? Well, I think that's a very important question. I'm afraid my background in genetics, I have often taken the view that I think if people wish to know their underlying genetic status, then that's something that they should be able to do. But of course, we live in an age where we have to consider how and why we offer tests. So sometimes it's not always appropriate if the genetic test, in a sense, isn't going to answer any specific questions. But as I've shown you, there is quite a considerable difference in the risk of disease progression between individuals with PKD1 and PKD2. And so sometimes finding out can be very helpful, especially for individuals who are perhaps at the early stages of their condition, and it's uncertain what the future may hold for them, or there is insufficient family information to also guide potentially how they may be affected in later life. So it is certainly something that can be considered. Your kidney consultant may have additional information, for example, about your kidney size or your level of kidney function at your age, which may provide just as accurate information. So again, it's just worth having the conversation with them. But genetic testing is becoming more available within the NHS. So I suspect more people will be considering testing in the future. So the next question is about the rare renal registries called RADAR in the UK. So will the RADAR program look to work with people who have been tested but have not identified one or two genes as part of research and development? Well, the answer to that is absolutely yes. RADAR is very much an evolving project, and for those without an identifiable genetic alteration, I think it is very much going to be within our plans to try and work out how we can improve genetic testing. That is something that certainly I hope will be offered in the future. As I said, the NHS in England anyway is going to be offering whole genome sequencing for individuals with no identifiable mutation. So that is certainly something that I hope will become available. And I would be very, very keen, if people were agreeable to it, that people who are participating in RADAR would make the results of their genetic testing known for RADAR, as that particular ADPKD RADAR registry now has some 5,500 individuals with ADPKD in it. So the types of questions we can answer about this condition, if we also have the genetic test results, I think are going to be very, very important going forward. I've got no more questions, Tess.
I just had a quick question in the last few minutes, which is, why is there such variability in family members who have the same mutation?
Yeah.
And that's something that I know from personal family experience in my family.
Yes, I mean, that is absolutely true. So you would have thought that within one family, with all individuals with ADPKD having the same genetic alteration, their disease would behave in exactly the same way. Well, we know that that is not the case. So the information that I provided earlier on the variability of the disease, that was amongst many, many different individuals who are not from the same family. When we look within families, there's perhaps less variability, but nonetheless significant variability. And we're not entirely sure why that variability occurs. It's almost certainly going to be what we would call environmental factors, such as diet, but again, many things have not been proven here, so I'm not going to stick my neck out and say things like caffeine, but we strongly suspect there might be dietary factors, there might be environmental factors. We know that good blood pressure control is something that is hugely important in ADPKD, which can slow disease progression. So sometimes people who've had undiagnosed blood pressure for many years may appear to have worse disease. We also know that other aspects of our genetic makeup, so-called genetic modifiers in animal studies, can also have a very significant influence on disease progression and severity. And I strongly suspect that there are going to be genetic modifiers in man, although the ability to identify those is going to take very large sort of genetic studies. But I think that will be one aspect of it. But essentially, the reasons for the variability are largely unknown.
Thank you. In the last minute, we've just got one final question that's popped up in the Q&A.
Yep. Shall I have a go at that one?
Mm-hmm.
So if my GP or local genetic testing team can't or won't offer me an MRI, having a family history of PKD, is there anyone else I can speak with? I think the answer to that is to find, well, I'm a firm believer in discussion and talking, is to find out why somebody's view about why an MRI might not be particularly helpful. And obviously ordering any test there needs to be a specific reason for doing that. We know that an MRI is a very good way of measuring kidney volume, but an ultrasound scan may also give important information on kidney length. An MRI, as I've already discussed, might be a very good test for trying to confirm a diagnosis, but sometimes I think getting a very, very clear idea about whether an MRI scan, for example, is required or not, sometimes does require conversation with an expert in polycystic kidney disease. So you're certainly more than welcome either to contact the charity or to seek the opinion of somebody else. But I think it's worth exploring the reasons why it's felt that the scan is not required first. So, I mean, I hope there are several options there. And I know that there are many kidney specialists who would certainly be happy to try and answer that sort of question for you in more detail. Oh, I've got one more. Can I keep going?
Oh, yes, we squeeze that one in.
Are conditions related to PKD tested for at the same time? The testing that is done specifically with PKD1 and PKD2 really is doing a test on the basis of testing for ADPKD. The two genes really are not associated with any other specific genetic conditions, although the type of genetic alteration or the number of genetic alterations might provide some additional information, but essentially it's a very specific test for ADPKD.
Wow, so thank you very much indeed. It's the end of the hour, went very quickly. Thank you, Richard, for sparing the time and for giving us a really up-to-date view of the genetics of polycystic kidney disease. As I said, if anybody's got further questions, please send them to me at info@pkdcharity.org.uk. Thank you all for attending. We will send around a feedback questionnaire link, and it's very helpful to get your feedback on these webinars so that we can improve and know what else people want to hear about. We're hoping to do far more of those in the next year. So thank you very much again, and good evening, everybody.
Great. Thank you very much, Tess. Good night.
Good night.